So I'm afraid we're going to have to press on because there's still quite a bit to go. Okay, so I'm just going to try and talk a little bit about first-line treatment for the fitter patients and for the less fit patients, and how that's changed really in recent time, how we manage higher-risk disease, and that's predominantly the patients with TP53 abnormalities, a little bit about relapse and refractory, and that this will, of course, incorporate the next generation of treatments, the novel therapies. So just to remind you, these are the groups of patients. And so the go-go patients are fit patients. The gold standard is still FCR, and that's a combination of fludarabine, cyclophosphamide, and rituximab. And that's because it was shown to be superior to FC alone without the rituximab, not only for the time that people remained in remission, but also for overall survival. And it was the first time ever a trial in CLL showed a survival advantage for a treatment. So that's why I said it was a real step change in terms of improving outcome. And the main toxicities are neutropenia and infection. And provided those are managed carefully, most patients will get through their treatment with FCR in a pretty straightforward manner. It's not always the case, but usually that is so. And the results are very good. And the results are particularly good for the subgroup of patients who have the mutated immunoglobulin gene and don't have any other genetic faults. And we've seen that from, don't be too bemused by this, but it's just to say that there are three very big sets of data from clinical trials and from other assessment that show that this group of patients do extraordinarily well. This is overall survival. So you're seeing here at 10 years, this is 72 months, at 10 years, 90% of the patients are still alive who had FCR, who had mutated genes. And here they are, that around 60% of them are still in remission. So a patient with mutated V genes receiving FCR has about a better than 50% chance that they'll still be in remission at 10 years. And I have a large number of patients now who are on this curve, and there's no hint of recurrence of their CLL, and it's quite possible that they may be cured. You have to follow people a long time with CLL to know that. But I think this is important for people to understand, because there's such a pendulum swing towards getting new drugs, new treatments. We don't want to throw the baby out with the bathwater and deny people a really extraordinary good result, because patients have 6 months of treatment. If they tolerate it well, and they're in a fantastic remission, they may have 10 years plus when they've got entirely normal life with no need for any interference from me or treatments. I see these people maybe once a year, and they're carrying on with entirely normal life. So we don't want to miss that. We can't predict exactly who's going to be in that position, but we can at least say who's more likely to be in that position. And the Italian data set suggested that these patients had a survival which was the same as an age-matched population. So in other words, the FCR wasn't doing any damage. They were not being affected by that. The Germans had sort of looked, I say not so go-go patient, but in fact, this trial was conducted on go-go patients. It was conducted on patients who were fit for FCR. And they were looking to see whether BR, which is bendamustine plus rituximab, gave equivalent effect, but with less toxicity. And the answer was fairly clear that the effect was not equivalent. It wasn't as good. So this is FCR and this is BR. So patients were relapsing more quickly after bendamustine rituximab than they were after FCR. And that was irrespective of their age. So the results were better with FCR, but there was less toxicity with bendamustine rituximab. So these patients didn't get as neutropenic, and they didn't get as much infection. So you have to sort of balance the benefits and risks here. So it's one of the judgments one has to make with patients as to whether you think actually it would be better to give something that's less toxic but perhaps slightly less effective, or it's better to go for the most effective treatment and just be careful about managing toxicity. But that's just because I think there is a sort of misunderstanding that BR is the same. It's not the same. It's not as good. and that's been clearly shown, but only for fit patients. It hasn't been compared with something for less fit patients, so we don't have that information. So for the slow-go patient, the patients that you feel would not be a suitable candidate for FCR, and that might be for a variety of different reasons, we now have a sort of FCR-like type treatment, which is using rituximab here, but combining it with a different chemotherapy backbone, in this case chlorambucil. So here we've got data from 2 trials. One trial looked at chlorambucil alone, comparing it with chlorambucil plus rituximab, and then chlorambucil plus a new antibody, which is called obinutuzumab. And then the other trial looked at chlorambucil alone versus chlorambucil plus another antibody called ofatumumab. Now these antibodies, these 3 antibodies, all target the same antigen on the surface, but they all have slightly different functionality. But they looked particularly at patients who were less fit. So if you remember, so the median age here is 72, so it reflected real CLL. The Sears score of 8, if you remember, 6 was the cutoff for whether people were fit or not, and 2/3 of the patients had a poorer creatinine clearance. So this was really a group of patients you wouldn't have wanted to give FCR to. And the results were astonishingly good in terms of improving the progression-free survival compared with chlorambucil given alone. And this MRD negative remission might come up on 1 or 2 of the slides. Really, it stands for minimal residual disease, but actually more appropriately, it should be measurable residual disease. So it's saying we can't measure any disease. We know there probably is some there, but the threshold of our tests doesn't detect it. And there's good evidence that certainly using standard chemotherapy, chemoimmunotherapy, patients who achieve a remission where we can't measure any disease anymore will have a better outcome. It will last longer. It's a bit intuitive, really, isn't it? The less disease you have, the longer it's going to take to come back. And that's true. And we'd never seen that with chlorambucil alone. It just wasn't effective enough to get those sorts of remissions. But when you add an antibody, it becomes so. And so this is looking just at the CLL11 study, which is where G is obinutuzumab, R is rituximab, and just shows the difference here. So, these were patients who got chlorambucil alone, compared with patients who got chlorambucil plus obinutuzumab in terms of the time it took before they needed treatment again. And it's a 3-year difference. So it's very significant for patients. And even comparing with rituximab, which is the older antibody, there was over a year difference. So this really has become pretty much a standard that's offered now to patients for whom FCR perhaps would not be your first, you wouldn't feel that was a safe choice for patients because we know we can really prolong the time that patients will be in remission before they need next treatment. And again, this showed a difference in overall survival. So for the first time for the less fit patients, there was a trial which delivered a better survival compared with the standard treatment of chlorambucil alone. And that was very exciting. So it meant that whether patients were fit enough for FCR or not fit enough for FCR, we could give a treatment which really made a difference to the natural history of the disease and improved survival. What about relapse CLL? Somebody asked this question. Retreatment, when clinically indicated, you use the same criteria that are used for first initiation of treatment. There is an inclination to start treatment earlier for a second treatment. There's no good reason for that. People can wait for a long time between when you first detect the disease returning and when they actually need to have treatment for it. So that's why that time to next treatment is quite an important measure, because it's longer than what we call progression-free survival, which is just when you can detect disease. There may be a year or 2 between those two time points. So same criteria apply. It's really important to repeat the TP53 test because that's something that can change over time. Somebody asked about the immunoglobulin heavy chain mutation status. That's a test that has to be done in a laboratory that has molecular analysis, but a lot of the laboratories will be able to do that. But you only have to do that test once because it's the same always. It doesn't change. But the acquired faulty mutations can occur at any time during the disease, so you have to keep checking for them. And also ruling out the possibility that the disease has changed into some different type of lymphoid malignancy which needs a different treatment approach, and often, usually biopsy would be required to confirm that. But patients who've done well with the treatment, you may end up giving them the same treatment again. Although, as somebody I think helpfully pointed out over there, people get older, don't they? If they've had 10 years in remission, they may not be the same individual that you treated 10 years earlier. You may want to think a bit differently about what you would give at that time point. So I think, bearing that in mind, however, if the remission has been short, and I'll show you what we do there, then that wouldn't be appropriate. It's now the case that we have a number of alternatives to offer. And this was also a question which I hope I've answered here. I would stay at any of these time points. Entering clinical trials is key. I meant to say this before I started even talking about the treatments, that as clinicians we're really very conscious of the fact that we're totally dependent on you as our patients to generate the data that I'm showing you, because that's all based on patients who went into those clinical trials and received those treatments. And without that sort of generosity, we couldn't make any progress at all in this disease. And hopefully for some of you, that may have actually ended up being a real advantage, because for a while, we were able to access some of the new drugs early for patients because we could put them into clinical trials before we were able to get hold of those drugs any other way. And I have a lot of patients who are on those drugs who were on them because they received them through a clinical trial. So we're enormously grateful. Hopefully for many it will be a benefit for patients as well, but sometimes it's just pure altruism, and we recognise that. So treating the high-risk patients, there are really two categories, to make it very simple. Those with high-risk genetic abnormalities, and we really home in on the TP53 because routinely people are not having tests for some of the other higher risk abnormalities. And those who have early relapse after FCR, so or any of the treatments really, but what we can anticipate that for some patients. We look back and they actually had a TP53 abnormality before they ever got that treatment. So one could predict it, but they're about, that only accounts for about 5 of the 25% who relapse early. So we can't predict for everybody. And what we know is that based on historical information, i.e. what we were doing 10 years ago, that the median survival for patients, whether it's because of this or because of this, is not good after relapse. But happily, that situation has changed now because the new drugs have changed everything. And when we were sort of, if you think about it, I did this for a talk I did at ASCO, which is the oncology meeting in the States, about what I would, this was a sort of 5-year front view, what we'd like if we had to design a new treatment. And obviously you want it to be effective for everybody. It shouldn't matter whether they're older, have comorbidities, whether they have these high-risk genetics, whether they've been refractory to standard treatments. You want it to capture all these patients who were difficult for us to treat at that time. A selected treatment that you could actually identify the patients that would benefit most from it, non-toxic, tolerable, easy to administer, oral, and that we understood how and when resistance might develop to the drugs. I think we've sort of tackled this very well with these new drugs. I mean, our big problem that remains is the cost effectiveness, in that these drugs are all very expensive. And that's outside our control, really, the other things. So again, I don't want you to get too bemused by the science here, but this is a B cell. CLL is a B cell, and there's something called a B cell receptor, and that receives signals from all sorts of different things in the environment, and a whole cascade. It's much more complicated than this. It looks much more like a London Underground map if you put the whole thing on. But essentially, signalling through here is what drives the CLL cell to survive and flourish, if you like. And so everybody thought, if the CLL cell is so dependent on this signalling through the B cell receptor to survive and not to die, then if we can cut it off somehow, if we can interfere with that, maybe we can make this CLL cell die and be removed from this sort of protection and proliferative drive, which means growth. And so a couple of drugs were developed that interfered with different parts of this pathway. I mean, in some ways, it's astonishing that they work so well because, as I said, if it's like a London Underground map, you'd think, well, actually, if you put a block on King's Cross, somebody would find another way round on a different line. But actually, interestingly, the cells don't seem to do so, and you can effectively switch the whole thing off by just blocking one bit of the pathway, either here, this is BTK, this is PI3 kinase. So these are the two drugs. You'll be familiar with these names. And what they do is they switch off this signal and allow the CLL cell to sort of stop growing and stop surviving as well as it does. And so Ibrutinib, this is the trade name Imbruvica, it's the first one that was developed as a BTK inhibitor. We now have another one that's in clinical trials called ACP, and it's given as a daily oral dose. And it is available for patients who've had at least one prior therapy. It's available or it's licensed, if you like, for first-line CLL if in the presence of a TP53 abnormality. And there is a license for first-line treatment, although it's not approved on NICE, so we don't have funding for first-line treatment, but there is a European Medicines approval for first-line treatment for older, less fit patients. So that's the position we're in, and those approvals were based on the fact that the trial, which was a one-to-one comparison of Ibrutinib versus ofatumumab, which is an antibody, so it's like rituximab. And these are the results, and you can see really that you don't often see such a big separation between the curves. So this is saying when people relapse. So every dot on here is somebody relapsing. And if they received ofatumumab, the median was about 8 months. If they received Ibrutinib, it wasn't reached at this 18-month time point. And the difference, if you looked at 1 year, 12 months, was the difference between 84% of patients still being in remission compared with 18% of patients still being in remission. So it's a bit of a no-brainer, isn't it, that this is better. I mean, if you were going into that study, which drug would you want to have? And happily for us, and we argued really hard with the company that sponsored this to get this as a global group, that you could cross over. So when this happened to you, you could cross over and get the more active drugs. So essentially all the patients ended up eventually on Ibrutinib who were able to get there. And these are the sorts of side effects that you see. Diarrhea is quite common. Fatigue is always pretty common with these things. Getting muscle and joint pains is fairly common as well. But no really serious ones. This is colour-coded. So grade 4, which is the really serious side effects, are in red, and there weren't any grade 4 side effects, and only minimal grade 3. So most of these were fairly mild side effects. And I know, having spoken to some of you, that there are a number of people in the room who are taking Ibrutinib, and you'll be able to report on how well you tolerate it. But there are side effects. And these are some of the ones, I think. Diarrhea and arthralgia seem to be very common when people first start Ibrutinib. They're usually self-limiting, they go away. Most patients will have a rise in the white count, and I'll show you something about that. There is a bleeding risk on this drug, and so one has to have specific care about other drugs that might be given that might also increase bleeding risk. Somebody asked, there were, I think, 3 or 4 questions about bleeding risk. CLL itself doesn't confer any bleeding risk. However, if the platelet count is low, obviously that's a bleeding risk. If patients are on other drugs that interfere with platelet function, which they might be for heart disease, or interfere with clotting, then yes, they're at increased risk. And Ibrutinib independently does give a risk of bleeding, and so it needs to be stopped before any surgical procedures. And there are various unusual skin things, erythema nodosum we've seen in several patients. Again, self-limiting. We've seen neuropathy in a few patients. We've treated a lot of patients now, and you begin to start to see some of these rarer side effects. And we see that patients who stop the Ibrutinib, if they have side effects, do better than those patients who stop who are stopping because of progression, and I think that's probably what you'd expect. This is the lymphocytosis. So the lymph nodes in green here go down very, very quickly, and I think anybody who's received the drug who had big lymph nodes will be aware of that, how very quickly the lymph nodes shrink. But in concert with that, you get this hike in the lymphocyte count, and it's really lymphocytes moving from here to here. So it's lymphocytes that are already in the body, and they're just being moved from one place to another. And when they get into the blood, they can't then get back into lymph nodes and the bone marrow. And it's in the lymph nodes, particularly, that these cells are nurtured in a cozy little environment that keeps them alive and flourishing. And if they can't get back in to get all that, then they eventually die from neglect in the blood. So this drug isn't really sort of killing them outright, it's not bang, the cell explodes. It's sort of separating them from their lifeline, their nourishment, if you like, and then they die because they can't get that. So it's a very different way of managing the disease, and people need to know this because, I don't know if any of you are like this, but quite a lot of my patients are very religious in their keeping their records of their blood counts, and they may have had treatment before. They expect the white count to go down when they get a treatment that works. They don't expect this to happen, so it can be quite alarming if people don't know that that's normal for this particular drug. And in terms of does it matter? No, it doesn't. It doesn't affect the response to the drug at all, whether you get a very high... I've seen somebody go up to 500, over 500 with a lymphocytosis after starting Ibrutinib, and it doesn't make any difference to the long-term outcome. And I thought I'd just give you an insight, because this is something some of you in this room may well be one of these over 300 patients, because between the trial that I've just shown you closing and the license being received for this drug, there was a 4-month period where the company made the drug available to us in the UK to use on a compassionate basis. And during that time, we put about 500, a bit more than 500 patients in the UK onto this drug. It was the same criteria as were used for the trial. And we've got good data, and George Follows has done a magnificent job at sort of tracking this data. It's not as robust as data that's collected in clinical trials, but it's still very useful, and it's just been published in a European journal called Haematologist. And again, these were older patients. 15% of them were over 80. They'd had a lot of previous treatment. Nearly half had had more than 3 lines of previous therapy. A third of them had the high-risk cytogenetics, and even this sort of almost a quarter had poorer performance status than probably would have allowed them to go into a clinical trial. So, you know, this was a high-risk group, and nevertheless, 3/4 of these patients still remain on treatment a year. And if they're still on treatment, it means that the treatment is still working and isn't causing side effects that have made them stop. So that's very encouraging that 3/4 of patients are still on the drug at 12 months, and 84% of them are still alive at 12 months. And if you reflect back to those curves I showed you where the median survival was only a couple of years for patients in these groups, then you can see that to have 84% still alive at a year is really, really encouraging. And the data was very comparable to the Resonate trial data. I'm going to skip through this. It was just saying it didn't matter what age.
Add something to that. All of that data from Haematologica and George Follow's slides are all on the CLL.
They're all on the CLL website.
They're on the CLL. So you can get all the details.
Yeah. So you can go back and look at this and much more, because I'm only picking and choosing. But it was just to say that it didn't matter what the age of the patient was. It didn't matter whether they had 17p deletion or not. It didn't matter how many prior lines of treatment. This is just saying that the results were the same, and that's unusual. You'd usually find with other treatments that patients who were older, who had 17p, or who'd had a lot of prior treatments, would do not as well. And the only difference was between patients who responded or didn't. And I think that's sort of what you would expect, that happily were not very many patients who failed to respond, but the patients who do respond have a fantastic outcome. So this is just showing what happens to patients when they stop the treatment. And sadly, there's a group of patients that do poorly, and these are the ones who transform to a high-grade type of lymphoma. Again, it's not a large number, but other patients who stop some of these will be salvaged, if you like, or by crossing over onto something else, another treatment. And this is showing the frontline data, which was just Ibrutinib with chlorambucil, showing again better outcome for Ibrutinib. That was what the license was based on, so it was approved on this basis. But the follow-up still relatively short. If you think for frontline CLL, 2 years is not very long. But that has sort of fed into the trial that we're doing in the UK, and some of you may be in this trial. It's sort of mentioned in several of the questions, the FLAIR trial, where we're comparing FCR. So this is the gold standard. So this is for patients who are fit enough to receive FCR. So it's not all patients with CLL, it's the fit patients with CLL. And we're comparing it with Ibrutinib plus rituximab. And this trial is recruiting very well indeed, but it's going to take a long time to get the answers on it, because here we've got a maximum of 6 years that patients can go on receiving Ibrutinib on the trial. And this is because the FCR data says that the median time that people remain in remission is about 5 years. So if you go longer than that, we ought to be able to compare and see whether patients are staying in remission longer on Ibrutinib plus rituximab than they would if they'd had FCR. And we're also using MRD, minimally measurable disease, to assess the difference between the two, because we know that about 40% of patients with FCR will achieve possibly a little bit more MRD negative remission. At the moment, we've not detected any patient on Ibrutinib who's MRD negative. Whether that matters or not, we don't know, because it's a different type of drug altogether, but that is one of the endpoints. The other drug is Idelalisib, similar oral drug. It's given twice a day. This one is actually NICE approved, which Ibrutinib is not yet. Ibrutinib's available still on the Cancer Drugs Fund. And so this is available for patients now. It's used in combination with rituximab, because that was the trial, and I'll show you. But there has been some concern about infection, and somebody talked to me earlier about being put on prophylaxis, actually on Ibrutinib. We actually, interestingly, maybe we're just a bit fussy at Marsden. We had patients on prophylaxis on both these drugs right from the outset because we weren't, a lot of them were heavily pre-treated, they'd had lots of other purine analogues, and so we've not seen any of these significant infections. But in the trials where it wasn't used and where patients weren't receiving any prophylaxis, there were some serious infections, even deaths from infection. And this is the data that that license was based on. Again, you're seeing exactly the same curves. This was placebo-controlled, so it was the best sort of trial you can do, really, in terms of not biasing the data at all. And here, Idelalisib plus rituximab was that much better than rituximab alone. So again, a bit of a no-brainer, and for survival as well as for progression-free survival. There are, again, toxicities. Some of them are similar to Ibrutinib, diarrhea as an early event, but there is a late diarrhea that can occur, 6 or more months on the drug, which can be more serious and associated with sort of inflammation in the colon, and often requiring discontinuation of the treatment. And there are also some respiratory problems. But, again, I don't think it's just with Idela. We've now seen reports in blood of respiratory pneumonitis with Ibrutinib. So I think, these are the sorts of things you have to expect when you use new drugs, that you'll start to see new toxicities that you haven't seen before. And they can also get, and again, same with Ibrutinib, the liver function tests can become slightly abnormal. They will often settle on treatment. And the same is true about patients discontinuing from adverse events. And this is a paper that's just come out in a publication, which is, sorry, no, not this one, I'm skipping. This is just to show that both these treatments work as effectively in 17p deletion as in those without. So it overcame that particular issue that people had. And that's just showing one of my patients, just showing the reduction in lymph nodes and the spleen. This is the spleen here. Somebody asked about how you know whether the spleen is enlarged. Well, you can feel it, actually. Somebody who does an examination, if you can feel the spleen, it's enlarged, essentially. And however much you can feel it is how enlarged it is. It doesn't really matter what it started out as. If you couldn't feel it before and you can feel it now, it's become enlarged. It's a very crude test, but it's actually very accurate, and you can see how the spleen has reduced in size there. No, this was the one I meant, which is showing what happens to people. It's a recent publication. If they stop taking one of these drugs because either of progression or because of side effects. And what it's saying really is that if people discontinue because of side effects, they have a much better outcome than if they discontinue because the treatment isn't working, they've progressed on the treatment. And particularly the Richter's transformation has a poorer outcome. But, what was really encouraging was that although, about half the patients who stopped because of toxicity, they had about a 50% chance that they'd respond to one of the other drugs when they started on that. And that they really had a pretty good survival if they had a good response to the alternative. So I've got patients now who've switched from one to the other and are doing very well on the alternative drugs. And as long as, one of the things I say now to people is you just need to stay one drug ahead of your disease, because as long as there's something to go on to that you've not had before, then you're probably going to be fine. And at the moment, they're coming along like London buses. So we're in a good position, I think. And this is one of the other buses. This is Venetoclax. And don't worry about any of this, how it works. The important thing from the patient point of view is that this is such an effective drug that it actually kills the cells, unlike the Ibrutinib and Idela, so fast that people get something we could call tumour lysis, which is really, if you kill a lot of cells very quickly, they release a lot of debris, if you like, and the body has to handle getting rid of all of that. And if it comes in very fast and there's a lot of it, then the body sort of struggles with it, particularly the kidneys. So it's something we have to look out for, and it's not something we see in CLL typically. It's something you only see in sort of very high-grade diseases. So now there's a very, very careful dose escalation of this drug. So you start on a very low dose and it goes up in small increments until by 4 weeks on treatment, patients are receiving the planned dose, and then they go on receiving that dose. But this point is monitored closely. Somebody asked about the risk. Well, the risk is all based on how much disease is there. If there's a lot of bulky disease, so particularly if there are lots of big lymph nodes or the spleen is very big, that makes patients have a higher risk and of tumour lysis. But actually in the trials, once they introduced this careful management, it's not been seen. So it was an early observation when patients went on not just 400, but they were going on to sort of 1,200 milligrams without a dose escalation. And this is what happens. So here the blood lymphocyte count goes down. So anything below the line is response. Anything above the line is not response. So it just gives you an idea. And if you get right down to the bottom, that's complete response. You don't usually see these sorts of results with a new drug where virtually every patient is getting 100% response. It's extraordinary high response rates and effective therapy. And this is saying that in patients with 17p deletion, an 85% overall response rate. Again, very, very high. I know some of these figures are a bit bemusing, but just trust me, you don't expect to see that in patients who are having a sort of late line of treatment. You'd be pleased with that result. I mean, that's the sort of result we see with frontline FCR. But to get it in a relapse group, and again, this is just showing how much the white count comes down, how much the lymph nodes come down, and these very high response rates. And for the first time, we're seeing complete remissions, which we don't see with the other two B-cell receptor inhibitors. And the data is very early, but these remissions do seem to be sustained. So this is out to 18 months and the median's still not reached. So they do seem to be durable. And I think what's important is that new data combining this drug with rituximab seems to produce an even higher complete remission rate, almost half the patients getting complete remission. And now, again, in those who get complete remission, more than half of them are MRD negative, which is not something we've expected to see with some of these new treatments. And here they did actually stop the treatment at 2 years, and patients have remained in remission. And that's the only data we have on patients stopping these drugs. Otherwise, they're on continuous therapy. So I just want to make the point of novel treatment, novel toxicity. No treatment is free from side effects. There seems to be this sort of dogma out there, promoted largely on websites, that these drugs have no side effects. You're going to be absolutely fine. And for a lot of patients, that is true, happily, but it's not the case for everybody. And you saw that 50% of patients stop the treatment because of side effects. So there are some that are quite significant. And the only reason I say that is because people who are receiving this drug must be aware of that. And if something odd happens, or you're not well, it's really important to make sure your doctors know about it, because there are side effects, including quite serious infections. Most of them are fairly mild and transient, and some can just be dealt with by a slight dose adjustment. But there are some potentially serious side effects and potentially serious infections. So although they're infrequent, I'm very mindful of it with my patient group. I have a lot of patients on these drugs. We still are very vigilant about the way in which we monitor them. There's none of this. What's happening in America is people have been put on these drugs and they're just sort of sent away, and they're thought that because it's an oral drug, it's not a problem. I think we've got to be, it's naive to think that it's going to be that easy forever. So the other thing is the drug interactions. I'm sure all of you have been given, who are on this drug, you've got lists of the things, including marmalade and grapefruit juice. And it's all in the patient information if you're on trials. But and usually we have the pharmacist actually meets with the patients who are on these drugs and goes through their other medications to make sure that there isn't any overlap. But the GPs need to know that, you know, they don't want to be starting on Cipro, on clarithromycin all the time. So the treatment, the way we treat patients is changing, and it's going to go on evolving as all of these new things come along. But it's important to know that, you know, what we've traditionally used as a prognostic marker, and maybe said this is a poor prognostic marker, that may not be the case with a different therapy. With a new therapy, if it works, that may no longer be a bad thing. That's what we hope. And we certainly are able to treat a lot of patients now very effectively who we couldn't treat well before, and with drugs that are easy to administer, oral medications. So that's just a summary slide. I don't think I need to go through it. We've said it already, but these are the drugs that are available and where we can use them. At what line of treatment, and obviously there are many other drugs available to patients through clinical trials, some of the newer ones, next generation drugs. So where do we go from here? And there are a lot of questions that we haven't answered yet. Importantly, we don't really know how these compare to standard therapies. The trials were done with treatments we don't really use, like single agent rituximab. We don't really use that. So the fact that you know, it's much better than that would not be a surprise. What we need to know is it better than what our gold standard would be? And that's why the FLAIR trial is so important, because we need to know whether it's better than FCR. The big question, and a lot of the questions that came through to me were related to this, is can we stop them? And if so, when? Well, we just don't know the answer to that question because it's not been done. And so patients who've stopped because of toxicity, some of them have gone on to do quite well, often because they've switched on to a different drug. But we don't know whether there's a point at which you can stop this treatment and the disease won't come back. We've seen people relapse very quickly, even when they've stopped just for a toxicity within a few weeks. So it will vary from patient to patient. I've had other patients who've stopped for toxicity and haven't restarted another drug for maybe a year or more, year or two. So there's going to be variation, and we just don't have the data. And FLAIR, hopefully, again, will give us some information on that. You know, we're going to be stuck as we were with CML, that nobody will know whether you can stop these drugs. And we don't know what the long-term side effects might be, and certainly about patients becoming resistant, because single agent therapy, whatever you do, whether it's an antibiotic or anything, if you give it long enough on its own, you're going to encourage resistance. And we've already seen that happening. And we don't know, you know, how much of a problem that might be. And of course, you know, with a long-term therapy that people go on taking forever, it's just not affordable. To be realistic in our healthcare system, it's not affordable to be paying £70,000 to £100,000 a year ongoing for a drug for one individual. You know, that's the reality of the situation. So, you know, we're not going to get, it will be much easier to go to NICE with a good argument for funding this treatment if we can say you stop after a particular length of time. So we are going to have results that hopefully will answer some of these questions from trials where they're compared. And there are a lot of trials ongoing, looking at combining some of these drugs to try and achieve a better response where you can stop the treatment and not get resistance, and obviously screening for resistance early. So I think I won't run through all of this, but it's you know, just again to thank people for being willing to participate in clinical trials and how important that's been in generating all this information. And you know, we've still got a lot of questions that need answering, so we still need people to be willing to participate in these studies.
What's the best way to access these trials?
Well, actually the CLL patient website will have information about the trials and often where those trials are open. Most of the tertiary centres will have some, if not all, of the studies open that are sort of relevant. It won't be open in all the hospitals that you're treated in. But I think if you need treatment, you can always ask whether there's a suitable clinical trial for you. And then it's your doctor's responsibility to find out whether you could access that. There are always sort of certain rules about who can have what. And so there may not necessarily be a trial that's suitable for you or for the person concerned. But it's always worth asking the question and finding out. And then you can get the information about the trial, and you can read it, and you may not want to participate in it. And that's absolutely fine. Nobody would ever put any pressure on people to go into a study. And you don't have to give a reason why you don't want to go in, and your management would be as the standard. Sorry.
Are there any treatment-naive patients that would be suitable for the Venetoclax?
Sorry, treatment-naive patients who've not been suitable for Venetoclax.
Would there be any treatment-naive patients that would not be suitable to join the Venetoclax trial?
Well, we haven't, at the moment, we haven't got a frontline trial with Venetoclax open here.
I thought you said there was one
No. There is, in Australia, which is the group that sort of have pioneered this, they have been treating treatment-naive patients and exploring combinations. And certainly there is an intention to do that within the UK, because the FLAIR trial is one that has the option of modifying it subsequently by changing the experimental arm combination. And so we're looking at things like combining Ibrutinib, Venetoclax and things like that. But there isn't a trial at the moment that a frontline patient, and that, you know, the suitability, so there isn't really anything that necessarily would make you unsuitable.
Just on the Venetoclax situation, that's still going through NICE.
But there is access to it at the moment.
There is some early access.
Early access on the
but
EAMS.
only for relapsed patients.
It's for relapse patients and for patients if they've got 17p deletion, if you've had a prior therapy.
There's also discussion about Venetoclax that the way that they're going through NICE is making it the parameters that they're using is going to make it difficult to get it approved, is my understanding.
Yeah, I mean, I think a lot of these things are difficult. I mean, you know, there was a little window for Ibrutinib and Idelalisib where they had no data for the use of these drugs in the front line, but because the results in relapse patients were so good for 17p deletion and so much better than had been seen with anything else, they sort of leapfrogged to get a sort of special exception to use frontline in patients. Now, it could be that Venetoclax is better in frontline, but you know, that's not been demonstrated, and it won't be able to capture that territory in the same way that those two drugs did, because it's already gone, if you like. It's no longer what they call an unmet need, i.e., you know, a patient group that don't have a suitable treatment. So that's why the license has only been given for relapsed 17p deleted patients, which is where the data was generated. And in fairness, that should be what it is for Ibrutinib Idelalisib, but it's very fortunate for us that we are able to use it in the front line.
Claire, do you have 20 minutes?
Yes, yeah, for further questions. I think I answered quite a lot of the questions, I hope, about the bleeding risk. Oh, other cancers. Yes, there's an incremental, a small percentage increased risk for patients with CLL of other cancers. Skin cancers, somebody mentioned. Yes, that is certainly particularly the non-melanoma skin cancers like basal cell carcinoma and so on. But it's not as high as people have thought, I think. There's been some interesting data recently from the MD Anderson to suggest it's not as bad as one thinks. Perhaps, but you know, the other thing to mention is that patients with CLL are living longer now. They're not dying from CLL, so they're living long enough to get another cancer, which they, you know, which people do as they get older. So, you know, in one sense, it's a product of the success story with CLL. Somebody asked about SLL. Was there evidence that the novel treatments were better? No, there's no evidence that having Ibrutinib is better than FCR if you have SLL. That's why SLL patients can go into the FLAIR trial. We don't know the answer to that. I mentioned 13q, Ibrutinib, MRD negativity, and I've spoken to somebody already, I think, about the genomic side, spleen, yeah, holiday insurance. I hope I've, oops, sorry, I think I've asked those. That was about getting a referral. Is there anybody who had a burning question here that I've not? Oh, somebody asked about infusion reactions with rituximab. I just saw that. Lots of people get infusion reactions with their first dose of rituximab. It needs to be managed carefully. We always split the dose. And I've had lots of people referred to me who presume to be allergic to rituximab, who we've very happily delivered all their rituximab treatment to. So it is conceivable that somebody could have a problem, but I've never seen it. We've given rituximab to...
It was severe. They won't give me rituximab. But on the FLAIR trial, I was unconscious for hours.
Okay.
Very severe.
Yes, I mean, sometimes they are. It depends. I think some of it is... Mostly it's preventable and manageable, but there will always be an exceptional case. So I wouldn't ever want to say it's inconceivable that you might not. I just think, you know, clearly if something life-threatening happens, you'd be a brave person to pursue that further. But I've seen more patients than I care to number who've been told that they can't have rituximab, who actually they're perfectly fine with it. It's just managed a little bit differently.
I just wanted to ask, you mentioned all these treatments, but you did not mention the stem cell transplant.
Ah,
So
yes.
is that
I thought I'd probably spare you from from that.
I mean, is it not an option now with all these good new novel medicines?
I think it's become less of high on the list of our considerations than it might have been. I would say, 5 years ago, we were saying if we had a young, fit patient who had 17p deletion, we would think about getting them into remission and transplanting them. That would be that was the standard of care then. And the pendulum obviously has swung completely the other way with the new drugs. I think probably a bit too far, and I think it'll settle somewhere where there will still be some people for whom a transplant may be the best choice. It will be fewer than previously. But it's something we shouldn't completely dismiss, because at the present time it is the only treatment that has definite proof of being curative. Nothing else has been shown to be curative. And I think, it's at a big risk for patients, but about 50% of patients who have a transplant may be cured. Now, for most patients, that risk is not acceptable. But there will be some, and one's just got to be mindful that we pick out the right people for the right treatment. It's all about that. And, I know people in this room who've had successful transplants and have benefited from that at a time when these drugs weren't available. And without it, they quite probably would have died from the disease. So, and I've got patients I look back on and think, if only these drugs had been available then we could have saved that patient. So the new drugs have changed everything, but have changed things hugely, but they haven't changed everything. So there will still be some patients who don't do well, even on these drugs. And I've already had patients who've not done well on these drugs. Now, I'm not going to dwell on them because I don't want to be pessimistic, but there are some patients. And actually, we could probably identify those patients earlier and maybe think then about a different strategy. And transplant is still there as an option.
How many years before you get the results of the trial?
Oh, we won't get full results from FLAIR trial for years and years. Patients aren't even going to finish their treatment for 6 years, and we haven't even finished recruiting the patients. And you can't even analyse the data until everybody's finished their treatment and you've got a year or two of follow-up data. So it's going to be a long time. Don't hold your breath on that one.
Can I just ask you about your slide earlier with the two cars, mutated and unmutated? How do you know
Don't hold it too much to it.
how do you know whether you've got mutated or unmutated?
Yeah, sorry, I thought I'd answer that because it was on one of the questions. I said you have to have a test,
Yeah.
a blood test. It's a straightforward, simple blood test, but it has to be done in a specialist laboratory that is able to conduct that test. It only ever needs to be done once. With a few caveats, it's pretty fixed throughout your history with CLL, unlike the acquired mutations. It's It isn't recommended as a standard test that should be done on all patients. So, if your doctors haven't done it, that's perfectly, they're following the right guidance. Not everyone will do that test. And it doesn't influence whether you should have treatment or when you should have treatment, which are usually the sort of important things that your doctor's thinking about.
About what treatment?
No, it doesn't even influence. Well, it might do. I mean, this is going to be interesting from the FLAIR trial because the data so far suggests that mutated patients do very, very well with FCR, and it will have to be seen whether they do better with FCR than with IR, for example. And the other way round is true for the unmutated. And we could see that with that data. We'll have that information.
Hello. I'm particularly interested in the comorbidity. You said something about comorbidity of cancers and the effect with CLL. I'm particularly interested on the effect of prostate cancer with CLL. I'm making treatment choices for prostate cancer at the moment based on the idea that hopefully I've got another 10 to 12 years with the CLL, but also my oncologist is saying 10 to 12 years with this hormone therapy treatment for the prostate cancer. And I can't get an answer from her about CLL.
Yes, it's probably the other way around as well. Well, working in a cancer hospital, as I do, because I'm at the Royal Marsden, I get a lot of patients who come to me via other cancer clinics because, and particularly prostate cancer, because it's men of the right sort of age who are otherwise doing very well and they pick up a lymphocytosis. So I've treated a lot of patients who have prostate cancer as well, and it's usually very straightforward. And what I always say to the other clinicians is you must do what you need to do to give the best possible treatment for that cancer. Don't be influenced by the CLL. In other words, I don't want them to compromise on treating the prostate cancer effectively simply because somebody's got CLL, which may never have an impact on that. Sometimes the presence of another cancer can be confusing. So just an example, I was referred a patient because they had picked up some lymph nodes incidentally on scans, and they weren't sure. They had assumed it was due to the prostate cancer. In other words, upgraded that to a higher risk category. This was now disseminated disease rather than local disease. And we just happened to pick up in their blood the CLL. They didn't know that. And so they referred with a very pertinent question, which is, are these lymph nodes CLL or are they prostate cancer? And I said, well, you don't know unless you biopsy them. So we actually ended up biopsying some intrapelvic nodes, and it was actually CLL. And so I was able to say confidently, go ahead, give them definitive, curative treatment for their prostate cancer. This is not disseminated prostate cancer. So, and I still follow that patient, and he's actually subsequently had treatment for his CLL, but you know, he's probably cured from his prostate cancer, and he might not have been if they had assumed that those lymph nodes were disseminated. They would have given him a different type of treatment. They wouldn't have gone for a curative therapy. So yes, it's a really important consideration, because it's not that unusual for people to have more than one cancer.
I hesitate to ask this question. Your view on alternative therapies for CLL. There's a lot of talk on websites, whether green tea,
Yeah.
turmeric,
Vitamin D, yeah.
Do you have a view?
I mean, my view is that most of those things are totally harmless, so, you know, why not? And there is a little bit of evidence, certainly for vitamin D and green tea, that they have some activity. I guess it's how much you have to take of it. I think they worked it out with the green tea. If you were just drinking it, you'd be taking gallons, but they do now have little sort of concentrated capsules. So, and I think one of the hard things for patients on watch and wait or watch and worry is that you've got a disease there that you feel you've got no control over, and you probably feel that your doctors don't have any control over either. And you're sitting there waiting for something bad to happen. And somehow doing something gives ownership. It makes people feel they're taking a grip of the disease and doing something about it positively. And that can be a very good thing. It can help people enormously to feel that they're doing something proactive. It might just be going to the gym, you know, and getting fit. It might be changing their job because they hate doing what they're doing. And actually, why do they want to go on doing that for another decade when, you know, this has perhaps prompted them to change? So things like that can be good. If it empowers somebody to be able to make a decision about something that makes them feel good about themselves and good about their disease, then I would never have any problem with that. Whether it actually does anything, I really don't know. We don't have strong evidence for it. But if it affects people's well-being, then it is doing something, isn't it? Even if it's not affecting the disease itself. I mean, there are some extremes that people go to that I probably wouldn't sort of, you know, twice weekly colonic washouts and things. I mean, I think it's a bit extreme, but you know, again, if people feel that that's really, really helping them. But I get quite a few people who've started vitamin D, come and they say, what's my white count, what's my white count? Oh, it's gone down 2. That must be the vitamin D. You know, you hesitate to say, you know, to dispel the idea, but actually it's probably got nothing to do with it at all. But if it makes people feel good, and we offer a lot of sort of alternative type therapies, from acupuncture to, you know, to massage at the Marsden. We do, you know, just to help people feel better, actually. You know, you're treating the whole person. It's not just these cells in the blood. So then there can be more than one way to do that, to achieve that, which is why I said, you know, do raise with your doctors the possibility of having some help with things, because there are all sorts of options that might be there to you know, to just support people. Yeah, sorry.
Do you feel that folic acid for mouth ulcers is, you know, does no harm, may well do good?
Yeah, possibly. I mean, there used to be quite a vogue for giving everybody folic acid. I'm not sure where it comes from. Most people, when you test their folate levels, they're perfectly normal. But yes, people who are plagued with mouth ulcers do sometimes get some benefit from folic acid. But as an overall, should all patients with CLL be receiving folic acid? I don't think there's any evidence to support it, unless they're deficient in it.
Do we have any more questions? Because I think they must leave very shortly. No? Okay.